I am a family physician and initially went out to Baltimore to study public health, and while I was there I was practicing in the community and really quickly recognized that in the setting where I was working, pretty much everyone had been impacted in some way by the opioid epidemic. Either they themselves had a history of opioid use or they had a loved one who had been impacted in some way, and realized that if I wanted to serve this community that it would be really critical that I learn more about treating opioid addiction, and I found that work to be extremely rewarding. Drug overdose is actually the leading cause of death for Americans under the age of 55, as reported by the New York Times based on their analysis of Centers for Disease Control data. We're seeing that this has now surpassed where we were at the peak of the AIDS epidemic, we were at the peak of gun violence deaths, and at the peak of car crashes. This is staggering when you think of the number of Americans who are dying of drug overdose, but also the families that they're leaving behind and the broader impact that this is having on all of our communities. The reality is right now that we're really in sort of crisis emergency mode, and so we're trying a lot of new things, often simultaneously. And often, in some cases we have research, but in other cases these are newer interventions. And so really the role of research is critical in understanding what's working, what's not working, and how do we continue to make it better. Specifically, the prescription drug monitoring programs have gained a lot of traction, and what research has shown is that these do reduce the number of people dying of prescription-related overdoses, and so it's really important that while we continue to focus on opioid prescribing, that we also focus on other interventions for people who are using illicit substances like heroin and fentanyl. In those cases, one intervention that's been extremely successful is the use of medication for opioid addiction treatment. Medications like methadone and buprenorphine, sometimes called Suboxone, which is a trade name, have been shown to reduce mortality by as much as 50% among people who have opioid use disorder. We also have interventions like distribution of naloxone. Naloxone is a medication that can be used to reverse an overdose, and it can be given to lay people, to people who use drugs, and they can use it to save someone's life in the event that they were actually overdosing. It's of course going to remain really important that we try to focus on primary prevention, reducing the number of people who initiate opioid use, but also equally important that we continue to meet people where they are. AIR is a social and behavioral sciences research and technical assistance organization, and we recognized that we had strengths in a variety of areas that were in some ways directly interfacing and in other ways really complementary or critical to working on the opioid epidemic. Oftentimes interventions were happening in a really siloed way, and so one of our goals in developing the center was that AIR would bring their expertise and really be able to better coordinate and work with systems in a variety of communities, whether it be at the federal or the local level, and really with the overall vision that we would be able to both create new research, new interventions, as well as work with communities and stakeholders to implement existing evidence-based practices to really make a broader impact on the epidemic. I think it's really easy to become overwhelmed by the numbers. And for myself, I found it really important to continue to hear those stories on an individual level, to understand the struggles that people have that both led them to substance use in the first place, but also the things that perpetuate substance use. And really using that lens to help myself better understand the research, understand evidence-based programming, but also to think really critically about the how and the why. Having the opportunity to meet people where they are, to really let them share their stories and try to offer tools, I think was a different way than I had ever been trained to work with people, and was just extremely rewarding. You know, I have so many stories of patients who have gone from really sort of very challenging social situations to then going on to get jobs, to reuniting with their families, to gaining housing for the first time in many years. And so all of these things really dramatically impact people's lives in ways that many other areas of medicine don't. For me, you know, these are the people who really have the answers. And so I find working clinically in the community is one of the most valuable parts of what informs my broader view of the opioid epidemic, because they're the ones living it and they're the ones that have a lot of solutions, and so I find that work really meaningful.